Yeah, so we're back with some consistent content now. And in this video today, I want us to look at multiple sclerosis. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at multiple sclerosis. If you haven't yet subscribed to this channel, please hit the subscribe button, hit the bell notification icon so you can never miss out on such amazing content every time I post. This is one of those conditions that you never really look at when you're in medical school, when you're in 5th year, when you're in 7th year medical school, even probably when you're in internship, you never really look at. But it's one of the conditions that is, in my opinion, an underrated neurological condition, because you may have seen a patient that may have come across with these particular symptoms. And I apologize for the noisy neighbors in advance. So remember that the nervous system is made up of the central nervous system as well as the peripheral nervous system. The brain and the spinal cord form the central nervous system. Then the peripheral nerves are going to be forming the peripheral nervous system. So when you talk about multiple sclerosis, what you need to understand is that it's going to be affecting predominantly the central nervous system. So it's a central nervous system disorder. It's an autoimmune condition that's going to be characterized by formation of these autoimmune T-cell mediated T-cell mediated auto cells that are pretty much going to be causing damage to the they're going to be causing damage to the white matter inside the brain and inside the spinal cord. So it's going to be leading to demyelination. There's going to be damage that is happening to the myelin, and then this is also going to eventually lead to damage to the axons. Remember that myelin is going to be very important for the transmission of electrical impulse. Remember that there are two main types of neurons, the myelinated neurons that have myelin sheath and the demyelinated ones. Remember, in the brain, you're going to be having the oligodendrocytes, which are the supporting cells that are going to be responsible for the production of myelin. Whilst in the peripheral nervous system, you're going to be having the Schwann cells, which are going to be responsible for formation of the myelin. So if you have this autoimmune condition where there is this T-cell mediated damage to this myelin, it's going to lead to demyelination, and this may actually slow the conduction of certain neurons. And way back, we actually thought that multiple sclerosis was a disease that affected predominantly the white matter. But as we looked more and more into neuroimaging, and we got to see that it also to some extent affects the gray matter, though at the early stages of the disease. So remember, like I already said, it's a chronic degenerative autoimmune T-cell mediated disorder. It's going to be affecting the central nervous system, causing this progressive demyelination, causing axonal degeneration in the brain as well as in the spinal cord. It's going to be characterized by what we refer to as lesions that are disseminated in time and in space. So what do I mean? The patient may come in with different symptoms at different times. For example, some months ago, they came in with eye symptoms, then they come in with different motor symptoms. They may sometimes even come in with cerebellar symptoms. And then when you look at the imaging, the MRI scan, you'll notice that there are some lesions that are at different stages of the disease compared to other lesions. So that's what we say, that it's a dissemination in space and in time. This is quite crucial for the diagnosis of MS or multiple sclerosis. Remember that it accounts for roughly about 2.5 million people globally, and it's the most common neuroinflammatory disorder in the West. There is actually a theory that says that those that are exposed to less sunlight as you move away from the equator, so as you move north, it's going to be pretty much going to be having much more greater incidence of multiple sclerosis. So there is a link to sunlight exposure such that people that spent their first 15 years of life in a temperate climate, they have a 1 in about 2,000 chance of developing multiple sclerosis than those that lived in the tropics, who have a 1 in 10,000 chance of developing multiple sclerosis. This is what we refer to as the vitamin D hypothesis, where there is some link to sunlight exposure, especially for those that are living far away from the equator, the northern hemisphere, they are going to be pretty much affected with multiple sclerosis, such that if an individual were to move from an area in the tropics and to move to that particular area with less sunlight, their risk of developing multiple sclerosis would be much higher than if they stayed in the place where they originally were. So this also suggests that there may be some genetic link. There may also be some environmental factors that may be associated. Remember that it's going to be typically seen in people between the ages of 20 to 40. It's rare that you get a diagnosis after 60 years, and it commonly affects women. If you look at the literature, most of the literature will tell you that there's a 2-to-1 predominance in females compared to males, but in reality, it's actually a 5-to-1. It's much more common in females than it is in males. And we see it much more greater in white individuals than we see it in Hispanic individuals. And we see it also much less in Black and Asian individuals for obvious reasons because of the distribution. Asians are part in the Northern Hemisphere, Black individuals, or Africans are in the Southern Hemisphere. Most of them, anyways, if we're talking about Zambia, to be specific. Then there is also some genetic links that have been associated, some genetic studies, and HLA genes have been associated with the onset of multiple sclerosis. And we actually see that the concordance rates are actually quite high in monozygotic twins. And when we actually look at the migration studies, like I told you, someone who lived in an area that doesn't have a high incidence of multiple sclerosis, if they move to a population where there is an area where there are people with high levels of multiple sclerosis or higher incidence of multiple sclerosis, they tend to actually have a much greater risk of developing multiple sclerosis. So there are certain key genetic and environmental factors that you need to be wary of in terms of multiple sclerosis. So remember that the underlying cause of this condition is not really known, and we actually think that it's an autoimmune condition. There is something that's known as a viral hypothesis, where there is some sort of molecular mimicry that is happening where someone is infected with a specific type of virus. There are many different viruses that have been implicated. EBV actually increases your risk of developing multiple sclerosis by about 12 times. Then HHV6, that's human herpes virus 6, has also been implicated in the development of multiple sclerosis. This may trigger a secondary autoimmune type of response. There are other environmental factors that actually have been triggered with the onset of multiple sclerosis. I already talked about the lack of exposure to sunlight, the vitamin D hypothesis, those that have reduced exposure to sunlight, those that cigarette smokers, significant risk factor. It's a modifiable risk factor, meaning that they should stop smoking if they're found with multiple sclerosis. It will slow the progress of the disease. But if they continue smoking, then obviously the progression of the disease may be much faster. Then there is something that's known as a hygiene hypothesis. And I like to explain this to my students. Have you ever seen someone that's coming from the compounds that has asthma? It's quite rare. Like someone coming from George, I have nothing about George compound, but someone coming from George compound, or someone coming from the deep, those shanty areas. Have you ever seen them coming with asthma or them coming with autoimmune conditions? It's quite rare. Why? Because they're exposed to all sorts of junk. The people that are living in the higher end communities are going to be exposed less to certain antigens, and their immune system is not trained so well, quote unquote, just that when they're exposed to certain antigens, it overreacts and actually leads to synthesis, or rather genesis of the autoimmune conditions. We refer to this as the hygiene hypothesis. So a reduced early life microbial exposure is actually going to increase the risk of autoimmune diseases. It's going to increase the risk of multiple sclerosis, increase the risk of other conditions, inclusive of asthma. And like I told you, there are some genetic factors that have been associated with multiple sclerosis, such that in monozygotic twins, there's like a 30% concordance rate that's happening, and 5% that's concordance rate in patients that are dizygotic twins. And there are over 60 different genes that have been associated. And most of these genes that are associated have a key role to play in the HLA class 2 alleles. So the human leukocyte antigen alleles, most importantly HLA-DR2. As you can see, some of these HLAs are going to be associated with other autoimmune conditions, diabetes, rheumatoid arthritis. So we have HLA-DR2, you have DRB1, you have DQA1, as well as DQB1. These are the alleles that are quite importantly associated with multiple sclerosis. And when we look at the HLA-DR15, it actually appears to be associated with much earlier disease. So the underlying pathological basis of the condition is not really known, but what we think is that it's a T-cell mediated autoimmune attack. So what is happening is that in the periphery, the lymphocytes are activated. Something activates the lymphocytes. It could be a trigger from a viral infection like an EBV. It could be a trigger from a human herpes virus 6 that's going to be activating this. So once now these lymphocytes have been activated, remember when there is an antigen that is presented in your system, it gets engulfed by the antigen presenting cells. Example are the Langerhans cells, the different types of macrophages in the body, and they phagocytose this particular pathogen and present an antigen. And once that antigen has been presented, it's going to be presented to the T helper cells. So the T helper cells are going to be activated, and once the T helper cells are activated, they produce cytokines to activate even other lymphocytes in the process. So this is actually going to be leading to these lymphocytes being activated in the periphery. And some of these lymphocytes can actually cross the blood-brain barrier and enter into the CNS, and they can actually damage the oligodendrocytes. So once they now begin to attack the oligodendrocytes, it will result in atrophy of the oligodendrocytes. It will result in loss of the axon. So this is what is responsible for generation of what we call the chronic plaques. Then eventually there's going to be some fibrosis that's going to happen. And this fibrosis is generally seen, and this is because there's going to be inadequate repair once this damage that happens. We call this as gliosis, such that the plaques are going to be seen in multiple different areas, and I'll show you the different areas where you could find these plaques. So like I already talked about, this activation of the T cells in the periphery, they cross the blood-brain barrier, they're going to be targeting the oligodendrocytes, they're going to be causing this focal demyelination, these acute plaques. Then if there's incomplete healing and incomplete repair, there's going to be gliosis that's going to be there. This is going to result in these chronic plaques about 2 to 10 millimeters. And generally you can find them in the optic nerves, you can find them in the periventricular regions, the corpus callosum, the brainstem, the cerebellar connections, and even the cervical spinal cord. This is very important because multiple sclerosis is a great mimicker. It can actually present as many different types of neurological conditions. So it's very important to know that if these lesions are in a particular place, they may actually present with certain symptoms. Now, way back actually, before I go any further, there was a condition that was referred to as Devick's disease, D-E-V-I-C, Devick's disease, which is now what we refer to as a neuromyelitis optica spectrum disorder. Way back, it was considered as part of multiple sclerosis, but as of now, we don't consider it as part of multiple sclerosis. It's actually considered as a different disease entity. And remember that generally gray matter involvement is going to occur early, but less extensive than the white matter lesions. The white matter lesions are the predominant things that we see in multiple sclerosis. So generally when you do an MRI, you may actually see many plaques, even in a patient that doesn't have any symptoms. We call this as a silent lesion that's accumulating. Then if as the damage is going on, the demyelination is going on, the conduction is reducing, this is going to result in these acute relapses where there's partial remyelination. So when the damage is going on, and the neurons actually demyelinated, conduction is slowed down. The person develops symptoms. Healing takes place, remyelination happens, they get better to some sort, but they never really return back to their baseline, but they recover. So that's why in some types of multiple sclerosis, you have some periods where they get worse and you have some periods where they get better. And then of course, this persistent axonal damage is going to drive this progressive disability that's going to be correlating with the gray matter damage as well as the cognitive decline. So now when it comes to the types of multiple sclerosis, I want you to remember predominantly 4 main types of multiple sclerosis. But before I come to this slide, I want to show you this particular image first. So the first type is the most common type of multiple sclerosis, which is what is depicted on the graph here. So on the left axis, we have disability. On the right axis, we have time. It could be in months, it could be days, it could be years. So the first type is what we refer to as the relapsing remitting type of multiple sclerosis. This one is the most common type of multiple sclerosis. It's what's depicted on the first graph on your screen. So this relapsing remitting will be alternating periods where they have this acute exacerbation that can last over days, and then they typically recover. They may either recover completely or they may take some weeks, but they never really return to the baseline. So as you can see, here there will be a flare up in the condition, then it eventually returns back, and then there'll be another flare up, then eventually it returns back. But remember that this return back to their baseline is not really back to normal neurological function. They may have some residual deficit that may be there. So some of these exacerbations have been linked with certain infections like influenza. So certain triggers, yearly triggers like influenza that we can see. And on an average, patients will have about one relapse per year, and occasionally they may have many years separating the relapses. And generally, when the deficits always resolves between the attack, we're going to be referring to this as a benign type of multiple sclerosis. We see this in about 10% of the patients. That's what we refer to as the benign multiple sclerosis. And then if this is not treated and it progresses, it may progress to what is known as a secondary progressive. So this was something that was initially relapsing, remitting, then eventually becomes what is known as a secondary progressive. So here now they have again periods of, initially they had periods of the relapsing and remitting, and then all of a sudden they get these exacerbations, and the exacerbations keep getting worse each time. And the newer exacerbations are independent of the previous ones. So even the residual neurologic deficit is independent of the exacerbations. So they have some residual neurologic deficit that is there. So this one here is seen in about 50 to 75% of the patients. So about 50 to 75 of these patients that initially started off with the relapsing remitting type of multiple sclerosis will now progress to have what is known as a secondary progressive multiple sclerosis. And generally, we have another type which is known as a primary progressive type of multiple sclerosis. This one is accounting for about 10 to 15% of the cases. So at the onset, they keep getting worse. So here, the symptoms continuously get worse from the onset without any relapses or remissions. And here there are some temporal plateaus, but it doesn't mean that they're getting better. They still have significant neurologic deficit, but with each exacerbation that comes, it's like they seem to get worse. Then we have a fourth type, which I haven't depicted on your screen here, which is known as the progressive relapsing type of multiple sclerosis. This one is quite rare. It's in less than 5% of the cases. It's the least common of the four. And generally, the disease is going to be progressing gradually, but then the progression is interrupted by sudden clear relapses. So we call this as the progressive relapsing. So it's progressing, but then there are some relapses where they get back to baseline. So this is what I've been explaining here with the relapsing remitting, 85 to 90% of the cases, the secondary progressive, which is accounting for about 50 to 70 something percent. Then you have the primary progressive, about 10 to 15%, and the progressive relapsing, which is less than 5%. Remember that your patients can move between the different types of multiple sclerosis over time because the disease is also evolving. And fatigue is one of the universal symptoms that you're going to be seeing in these patients that have multiple sclerosis. And it may be seen in the different types or different forms of multiple sclerosis. So remember that how is this patient going to present with multiple sclerosis? It's a very diverse neurological symptom, or rather diverse neurological condition. It's going to be called the great imitator, like I told you, because it can present with many different things. And generally, the clinical features are going to depend on where the lesion actually is. So remember that we say that multiple sclerosis is this focal neurologic deficit that is spread out in time and it's spread out in space. In space, what do I mean by spread out in space? They have different areas of the brain that are affected, resulting in these different symptoms. And then in time, you have presentations at different times. So generally, common initial symptoms that patients actually tend to present with are things like paresthesias, where it may affect one or even more extremities. It may be in the trunk, it may be on one side of the face, and it's not corresponding to any single possible lesion. Because if someone comes in with weakness, for example, on the left side of the body, you're able to localize that possibly the lesion is on the right side of the cerebral hemisphere. But in this case, you get these weird symptoms that don't make any sense, and no single lesion can actually explain the symptom that the patient has actually come in with. Sometimes they may come in with weakness or clumsiness of the leg or hand, not corresponding to any single possible lesion. And generally, visual disturbances are quite common in these patients. And the three characteristic presentations that we see in patients with MS, you have optic neuropathy, which are the optic neuritis, the visual symptoms, very common. Then you have the brainstem demyelination, and you also have the spinal cord lesions. These are actually common. And remember that these symptoms can actually vary in severity. They may vary in frequency. And if the patients are untreated, they'll experience this exacerbation about every 2 years. There is some phenomenon that's known as the Uthoff's phenomenon that I just want to talk about that's not really pointed on the slide here. So Uthoff is spelled as Uthoff. I know I talk very fast. That's why I want to actually spell it out for you guys. So the Uthoff. So the Uthoff. So this is just simply when a patient that has multiple sclerosis actually takes a warm bath or they get a viral infection, to actually exacerbate their neurological symptoms. So we refer to this as Uthoff's phenomenon. Remember that especially for the exams. Then what are some of the visual manifestations or the eye lesions? You may have what is known as optic neuritis, which is one of the earliest signs in multiple sclerosis. So there'll be this painful eye movements. They may have this visual impairment. So it may range from them having scotomas in their eye, in their visual fields. They may actually even go blind. There may be some color blindness as well. They may have abnormal visual fields and even loss of visual acuity. Then they may have a swollen optic disc. Then one important finding is what is known as the Marcus gun pupil. So remember that naturally, when you shine light in one eye, that eye is supposed to constrict. Then when you swing the light quite quickly to the other eye, that other eye is also supposed to constrict. You refer to that as the direct and the indirect pupillary light reflex. So the eye where you didn't shine the light in initially is also supposed to constrict because of the pathways. I'll dive into the physiologies on my other channel when we look at the visual system. But for now, just believe me that when you shine light in, for example, the right eye, there's supposed to be constriction of both the right pupil as well as the left pupil. So in patients that have multiple sclerosis, they may have what is known as a Marcus gun pupil, or other books refer to it as a relative afferent pupillary defect, just simply going to be indicating that there's asymmetrical damage to the optic nerve or even to the retina. So when we have a rapid afferent afferent pupillary defect, so when one eye has reduced afferent or sensory signals because maybe the optic nerve is damaged on that side, or maybe they have retinal disease, when you shine light in that affected eye, there will be constriction of both pupils, but it will be less in that affected eye. When the light is shining in that affected eye, both pupils will constrict, but it will be less when the light is shown in the healthy eye. So when you shine the eye in the affected eye, there is constriction, but it's less. But you shine it in the other healthy eye and swing the light back, the constriction is noted to be more. We refer to this as a relative afferent pupillary defect. So there's going to be this paradoxical dilatation of the pupil when you're switching from the healthy eye to the affected eye. That's the hallmark of what we call the Marcus gun pupil. Then there's something that's known as the internuclear ophthalmoplegia, or the INO. So generally this is because you're damaging the medial longitudinal fasciculus, and this is causing an impairment in the horizontal gaze with adduction deficit and abducting nystagmus. That's very difficult to actually read through. So I'll just explain it to you like this. So when your eye, let's say your left eye, is looking towards the left side of your body with your head still, the right eye is supposed to also move towards the left side. So if an eye moves towards the nose, we refer to that as adduction. If it moves away from the nose, we refer to that as abduction. So when the left eye abducts, it moves away from the nose. The right eye is supposed to adduct. It's supposed to move towards the nose. Now, if someone has an internuclear ophthalmoplegia and you perform those eye movements, then when there's now horizontal gaze and they're trying to look to the opposite side, what you'll notice is that one eye is going to abduct, and then the other one is going to just be having this nystagmus, this jerky horizontal movements. We refer to that as an intranuclear ophthalmoplegia. Generally, this is often pathognomic, considered by some experts as pathognomic of multiple sclerosis. In some other instances, patients may have some brainstem lesions. So patients may present with double vision, which is diplopia. They may present with vertigo. They may present with facial numbness and weakness. They may present with difficulties in pronouncing things, dysarthria. They may present with dysphagia. And typically the patients, like I said, are going to be having the bilateral intranuclear ophthalmoplegia, which is quite characteristic of multiple sclerosis. Then remember that the visual and even ocular signs are going to be essential for neurological examination and for the differential diagnosis of multiple sclerosis. Other patients may have increased incidence of epilepsy, they may have trigeminal neuralgia, they may have tonic spasms. And generally, the multiple sclerosis can also affect the spinal cord. So it may affect the motor aspect of the spinal cord, it may affect the sensory aspect, it may also affect the cerebellum and even the cranial nerves. So if it's affecting the motor aspect, there's going to be weakness. So generally in the cervical and in the thoracic, if those are involved, there may be difficulty in walking, and usually this is going to be reflecting that there's a damage that's going to be happening in the cortical tract. And remember that the corticospinal tracts are the ones that are going to be responsible for contraction of those muscles. You may also have the deep tendon reflexes, which are going to be increased. So they're going to have these brisk deep tendon reflexes, and there's going to be this extensor plantar response, what is known as a Babinski response when you do the Babinski at the lower limb. There may sometimes even be clonus. Remember that multiple sclerosis is a type of upper motor neuron lesion. Remember the difference between upper motor neuron lesions and lower motor neuron lesions? Upper motor neuron lesions, remember, everything goes up. So the muscle tone increases. Babinski goes up. You have clonus, and then in the lower motor neurons, there's a flaccid, the muscles are flaccid, the Babinski is going down, and of course, the reflexes are also going down. So generally, you may have an upper motor neuron findings. Then there may sometimes be painful flexor spasms that may be there. Sometimes you may get what is known as this progressive myelopathy, which is a variant type of multiple sclerosis. And sometimes you may have an absent abdominal reflex. Then in terms of sensory, the sensory system, I want you to remember two important things that are often tested on the exams. The first is what's known as the Lemite sign. Lemite is L-H-E-R-M-I-T-T-E. Lemite sign. I'll repeat, L-H-E-R-M-I-T-T-E. So generally what happens with the Lemite sign is that there's going to be involvement of the spinal cord. So once the spinal cord has been involved, if you now flex the spine or you flex the neck, you ask the patient or you take the patient's chin and attempt to put it on their chest, they'll have this sharp electric-like pain that they'll feel that's shooting down their spine. We refer to that as Lemite sign. A high yield point, very much tested on exams, very important to remember. Sometimes they may have this tight sensation, this tight band-like sensation around their abdomen or even around their chest. We call that as an MS hug. An MS hug, a multiple sclerosis, like someone is hugging you there. Then sometimes you may have involvement of the spinal cord, which may result in bladder dysfunction. So they may have this urinary urgency, they may have hesitancy, they may have this partial urinary retention, they may have mild incontinence. Sometimes they may have constipation, they may have erectile dysfunction, they may even have this genital anesthesia in women. And generally, remember that the spinal cord lesions are a common cause of these patients actually presenting with neuropathic pain. Like I told you, this multiple sclerosis is a great imitator of many different things. So they may have autonomic dysfunction, they may have urinary incontinence, they may have sexual dysfunction, especially in the early stages of MS. Then you may also have some cerebellar symptoms. Before I actually move on, you may have some cerebellar symptoms. So they may present with cerebellar ataxia. Sometimes they may have slurring of the speech. Sometimes they may have a scanning speech where they have this slow enunciation with a tendency to hesitate at the beginning of a word or at the beginning of a syllable. Then you may have what is known as a Charcot's triad. Charcot's triad is simply the intentional tremor. They have a scanning speech and they have nystagmus. Another high yield thing that's tested on exams, Charcot's triad, which is intentional tremor. You also have a scanning speech. You also have nystagmus. The cranial nerves that are generally commonly affected in multiple sclerosis are cranial nerves number 7, or rather not 7, 9, 10, 11 are usually spared, but cranial nerve number 7, yes, cranial nerve number 7 and even cranial nerve number 3 are going to be commonly affected. So looking at what I have on your screen there, remember that diplopia, vertigo, facial numbness or weakness, along with dysarthria and dysphagia are going to be suggestive of brainstem involvement. Then in those patients that have limb pyramidal signs, they may appear to affect the corticospinal tract, and it may result in spasticity and gait difficulties. Remember, this is an upper motor neuron sign. So they may have diplopia and vertigo with nystagmus. It's typical without tinnitus or hearing loss. They may sometimes have a bilateral intranuclear ophthalmoplegia. Like I said, it's often a hallmark of the disease, considered by some experts. So it's very important that to understand some of these symptoms, because you want to actually pick them up. Someone will tell you that, oh, I came in last month with my eye hurting when I moved it. I was seeing things and then I went blind. All of a sudden, today I've come in and I'm having numbness of the limbs, and then that's the only thing. You examine the patients, you find out that they have no other symptoms. Then you're thinking this could be multiple sclerosis. So I've already talked about this, the motor symptoms from the spinal plaques. I've also talked about the sensory system. I've talked about the limite sign. I've talked about the MS hug. I've talked about the neuropathic pain. I've also talked about the motor signs and even the autonomic signs. So you can pause the video at this particular moment, get a screenshot, or actually just read through, because I've already explained what I've already depicted here. And then I've already talked about the Charcot's triad. So like I told you, the common nerves that are going to be affected: cranial nerve number 3, the ocular motor; cranial nerve number 7, the facial. While as cranial nerve number 9, 10, and 11 are going to be spared. Then you may have what is known as a pedular nystagmus. It's quite uncommon. This distinct eye movement sign that's seen in multiple sclerosis. There may be vertigo. There may be intermittent facial numbness or pain. Well, that may mimic this trigeminal neuralgia. There may be this mild dysarthria, which I already talked about. And generally in advanced type of MS, they may have ataxia, they may have spasticity with slurred speech and even scanning speech. In the late phase, they'll have this severe disability. So they may have this spastic tetraparesis, they may have ataxia, they may have optic atrophy. And generally, they'll have the bilateral internuclear ophthalmoplegia and the nystagmus. They may have the pseudobulbar palsy with urinary incontinence. In advanced stages, they may have cognitive impairment. And then the median time to require walking aids is roughly about 15 years from the onset of the disease, meaning that once you get the disease, in about 15 years' time, you won't be able to walk and you'll be wheelchair bound. So the median wheelchair dependency occurs roughly in 25 years post-onset. And of course, an early diagnosis and treatment is actually going to delay severe disability. It's not going to stop the disease, it's going to delay severe disability. Remember that there is no cure currently for this. So how do we make a diagnosis of multiple sclerosis? Remember that given that it's a mimic of many different conditions, you actually have to make a diagnosis of exclusion. So you have to exclude a lot of things before you actually come to make a diagnosis of multiple sclerosis. But it can be supported by certain tests, such as an MRI, which is the gold standard. You can do what is known as a T2 weighted image, which will show these hyper intense plaques. I'll show you what they look like on the next slide. So here is a picture, a cross section of a spinal cord, showing you these plaques. As you can see, here are the plaques. I've pointed them out with an arrow there, that are seen in the posterior column. We can also see them in the lateral corticospinal tract. Then here are also other lesions. Remember that the lesions tend to be periventricular, so they tend to be very close to the lateral ventricles. So here you have these brain plaques over there, and they are oval in shape in this particular picture, about 2 centimeters, and they are perpendicular to the lateral ventricle. And we have this characteristic image here, which is common in exams. So this is what we refer to as Dawson's fingers. So these are also plaques that we see in multiple sclerosis. We can also note that there's some significant atrophy of the brain here. You can see that the ventricle seems a bit larger, and you can see the spaces between the sulci spaces and the gyri, which appear a bit shrunken in that particular picture. So like I said, it's a diagnosis of exclusion. MRI is the gold standard. You could do gadolinium enhancement, which can indicate active inflammatory lesions. You may sometimes get T1 black holes that may represent permanent axonal loss or chronic damage. And there is a criteria that's known as the McDonald's criteria. The 2017, there's a revised one, the McDonald's criteria, where you actually make a diagnosis. So generally, if a patient presents to you, for example, so remember that with multiple sclerosis, it's a dissemination of the lesions in time and in space. So number one, they mustn't have any other diagnosis that can explain their symptoms. or they have one of the following things. So if they have 2 or more attacks with 2 or more lesions on the imaging, then the diagnosis of multiple sclerosis can be made clinically. If they have 2 or more attacks plus 1 lesion, then generally and they have historical evidence of a prior attack in a different location or MRI scan showing a dissemination of the lesion in space, then you can make a diagnosis of multiple sclerosis. Or if you have 1 attack with 2 or more lesions, so the MRI is showing a dissemination of the lesions in time, or the CSF, if you do a CSF for these patients, you tend to get what is known as oligoclonal bands. So if you do a CSF and they are oligoclonal bands, then you make a diagnosis of multiple sclerosis. The other possibility is if they have 1 attack with 1 lesion, but then they have an MRI showing the dissemination of the lesions in space and the dissemination of the lesions in time, or they have the CSF showing the specific oligoclonal bands. That's very important to remember because it shows up on exams. Then you can make a diagnosis. Or if they have progressive symptoms from the onset, that's the progressive or the primary progressive multiple sclerosis, where there's more than 1 year of progression plus 2 of the following things, where they either have more than one or more typical brain lesions, 2 or more typical spinal lesions, or they have CSF which is consistent with the oligoclonal bands, then we say that this patient can meet the criteria, the McDonald's criteria for multiple sclerosis. You can also do evoked potentials for the visual and auditory as well as somatosensory to assess the CNS functional impairment. Some other blood tests must also be done to rule out any other causes that may mimic multiple sclerosis like sarcoidosis and infections. So some of the differential diagnosis that you want to think about: subacute combined degeneration of the spinal cord. Remember, this is going to be B12 deficiency. Remember, B12 is very important in the development of the nervous system, and the maintenance of the nervous system. It's very important in the synthesis of red blood cells. So if someone has a B12 deficiency, they may develop a neurological complication that's known as a subacute combined degeneration of the spinal cord. So in this case, they may have this progressive sensory loss and myelopathy, but here you want to check your vitamin B levels. You also want to check your methylmalonic acid levels, and then you also want to be checking your homocysteine levels in this particular case. When you do a peripheral smear, you're going to see hypersegmented neutrophils in this case. Then you can also have spinal cord neoplasms and atriovenous malformations. Generally, these ones will have this lateralizing symptoms, unlike MS, which will have this fluctuating course. You may also consider a cryptogenic stroke. These occur mainly in older individuals, and they have less focal neurologic severity than the typical MS episodes. You may also have amyotrophic lateral sclerosis, which should be Lou Gehrig's disease. So this one here presents with this lower motor neuron signs, and sometimes they may have muscle atrophy as well, but they don't have typical features of multiple sclerosis. So it's very important to actually get a full history. It's very important to do a good examination. It's very important to order for appropriate investigations, because multiple sclerosis can actually mimic many things. So in terms of the management, remember the core pillars of management in multiple sclerosis. Generally, we want to treat the acute exacerbations because they're going to be shortening the relapse duration. You want to use long-term disease-modifying agents to actually reduce the frequency and slow the release, or rather slow the disease progress. You also want to manage the symptoms to alleviate complications and maintain patient mobility. You also want to focus on immune system modulation to improve the quality of life of this particular patient, and you want to employ a multidisciplinary approach. So you want to involve the neurologists, you want to involve the therapists, you want to involve support services for this particular patient. So generally, if they come in an acute exacerbation, what would you do? So you want to taper down or hush down the immune system. So you want to start them on high dose of steroids. So generally, we initially give them a high dose of IV methylprednisolone. That's about 500 to 1000 milligrams daily for 3 to 5 days. Then you can follow this with prednisone oral tablets that they can taper off to reduce the inflammation and to speed the recovery of these patients. Remember that the steroids are going to accelerate the improvement of the symptoms, but they are not going to have an effect on the long-term disease. Alternatively, you could do plasmapheresis as an alternative, especially for those that are coming in and you've tried the steroids, they're not working, they're steroid resistant, the type of multiple sclerosis. This actually removes those antibodies from the body. You may consider ACTH gel. that can actually stimulate endogenous steroid production when the steroid is actually contraindicated or they are ineffective. But again, you want to exclude any infections before you actually start giving corticosteroids to this particular patient, because you may worsen those infections. And then, of course, clinical improvement typically is going to occur within days when you start the treatment, which will enable your patients to return to their normal functional status. Then, in terms of now treating the long-term disease, I just want you to remember two important drugs. One is interferon beta 1, which is an interferon type of therapy. And the second drug I want you to remember is glatiramer acetate. So the first two, interferon therapy, so interferon beta 1 as well as the glatiramer acetate. So the remember the different types of or progressions of multiple sclerosis. You have the relapsing remitting disease, you have the secondary progressive, and you have the primary progressive. So the relapsing remitting is the commonest type. The first two drugs are the ones that are commonly used. The interferon therapy, that's the interferon beta, and glatiramer. Those are the two important drugs that they will ask you on your exams. Then Spinomod can also be used, and some monoclonal antibodies have actually flooded the market and are in use. Then secondary progressive, the therapies that you used for active secondary, all the disease-modifying therapies can actually be used for this active secondary progressive multiple sclerosis. But for those that have primary progressive, you want to use monoclonal antibodies, your ocrelizumab. So here are the three main drugs that we use. You have the injectable platforms, the monoclonal antibodies, the oral therapies. I'll just go through this table because I put a tables on the different classes that I won't really go through, but I'll give you time to pause the video so that you can have a look at the dosages, the side effects, and but the take-home message is pretty much on this particular slide. So you have injectable platforms. These are meant to be immune modulators which work via interferon beta or T-cell modulation. They can be administered either subcutaneously or intramuscular. These ones have a moderate efficacy. They reduce the relapsing rates and also the generation of new lesions, but they have side effects of flu-like symptoms and even some reactions at the injection site. The monoclonal antibodies, these ones are targeting the different areas of the pathogenesis cascade. So they're going to be targeting the immune cell depletion or even sometimes blocking certain pathways. So these ones are given IV. So these ones have a higher type of efficacy, so they are superior, and they are going to be reducing the lesion formation. But there is a big risk of progressive multifocal leukoencephalopathy, which is why these drugs are not commonly used. There's a big risk of progressive multifocal leukoencephalopathy, especially with a drug that's known as natalizumab. Then they also have some autoimmune complications that may be seen. Fingolimod, which is a type of a newer drug which is given orally, and oral therapy has actually been seen to cause diabetes mellitus, for example, has been seen to cause macular edema, even prolongation of the PR interval. So the last part, which is oral therapies, an example I've already given you is fingolimod. This one is immune modulators. Some of them are sphingosine 1-phosphate receptor modulators. These ones are given orally. They have a moderate to high efficacy. They are convenient, but they have variable efficacy across the different groups. They have liver toxicity, they have lymphopenia as risk factors, and they have infection risk factor. So here are the platform injections. So your glatiramer as well as the interferon beta. Then here I've put for you the natalizumab and the other antibodies, ocrelizumab, which I've put for you, and the how they are given. And here are the oral medications, your dimethyl fumarate, your fingolimod, and so on and so forth. So here's a table to show you all the drugs that we use in the treatment of multiple sclerosis. You can pause the screen, take a screenshot of this. I think I won't be going through this step by step because I think it's a self-explanatory thing. So remember that in symptomatic treatment of multiple sclerosis, there are certain things, certain complications that we actually want to manage. So remember that the spasticity, we can manage it with baclofen, dantrolene, tizanidine, as well as diazepam. And then you can alleviate the fatigue by giving them amantadine and even modafinil. You can treat the neuropathic pain with things that we use to treat trigeminal neuralgia, for example, tricyclic antidepressants, carbamazepine, gabapentin. The bladder dysfunction can be treated with anticholinergics and even bladder training methods. Then if they come in with urinary retention, this can be treated with catheterization and bethanical. Then, of course, there should be some support for sexual dysfunction, giving them sildenafil and some lubricates. So remember that you should individualize the treatment of multiple sclerosis, and you're going to be managing them to improve their quality of life. But generally, these are not going to alter the course of the disease, and generally there are some different side effects and there are different drug-to-drug interactions which you should be quite wary of. So generally, in the long term, you want to schedule reassessment of this patient at 6 months after they start the interferon beta or the glatiramer to detect any new lesions and to guide the treatment to adjust the dose. Then also to implement regular follow-ups for these patients to monitor the disease stability and treatment response. And of course, involve other people, the neurologist, occupational, physiotherapy, and even the physical and speech therapy, and even psychological support must be present. And remember, you should educate the patients on MS, the treatment expectations, the lifestyle factors that they must modulate. So things like smoking, they should stop smoking, they should exercise, have a good diet, and treat any comorbidities. Screen them for depression. Remember, this is a chronic disease. They have a high risk of depression. Screen them for depression. If it's possible, start them on an SSRI, the serotonin, selective serotonin reuptake inhibitor, and link them to psychiatric help. Then, of course, advise them for vitamin D supplementation, though evidence against this is weak, as its effect on the disease is actually not truly known. I really hope you enjoyed this video on multiple sclerosis. I know it was a mouthful to actually deliver, and I know it's probably more than a mouthful for you to actually take. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.